This discussion will focus on different psychotherapeutic drugs. So we have here anti-anxiety, anti-manic drugs, antidepressant drugs, and antipsychotic drugs. And with this is that it will focus more on reducing anxiety, any mood disorders. So the thing with anxiety, it's unpleasant state of mind characterized by sense of dread and fear. And it can affect the social engagement of your client. And remember that also anxiety is clinically related to OCD, obsessive compulsive disorder, post-traumatic stress disorder, generalized anxiety disorder, panic disorder with or without agoraphobia. And agoraphobia means fear in being in a crowded place, social phobia, simple phobia. And so with anxiety, we give them anti-anxiety drugs. And this anti-anxiety drugs, we also give it to clients who have seizure, like benzodiazepines. We also give that to stop seizure. So benzodiazepines depress activity in the brainstem and limbic system. And we have miscellaneous drugs like buspirone. It's non-sedating and non-habit, because with benzodiazepines, it can also over-sedate the client if we're giving too much. So with benzodiazepines, the most commonly used are diazepam, lorazepam, alprazolam, clonazepam, and chlordiazepoxide. So just a review, lorazepam, we use that to stop acutely any episode of seizure. But for this discussion, we also use it to reduce anxiety. Now, the thing with anti-anxiety drugs, you have to really monitor your client closely for any oversedation and any change of level of consciousness and any profound CNS depression, because really the goal here is to reduce anxiety but not to oversedate them, nor not to treat the depression itself. Okay, because anxiety can also lead into later on depression. So other name for anti-anxiety drugs are anxiolytics. So the therapeutic effects that we want to see for clients who are taking anxiolytics are improve alertness, improve sleeping patterns, they are more socially engaged. And remember that giving it with grapefruit juice is not a good idea, not only for anxiolytics but also other drugs like calcium channel blockers, statins, SSRIs, cyclosporin, which is an immunosuppressant, carbamazepine, buspirone, and sakinavir. Now, before we move on to affective disorder drug, remember that with benzodiazepine, the antidote is flumazenil. So I'm just gonna write it here somewhere. Flumazenil. So this is the antidote for benzodiazepines. Now, the second type of drug that we need to talk about are the mood stabilizers. So these are given to those clients who have affective disorders. When I say affective, we're talking about mania. Mania is exaggerated emotions, to depression, and depression is fewer emotions or emotional range. So, like for example, client who have bipolar disorder. With bipolar disorder, your client has two extremes. So there might be in a manic episode or there might be in a depression episode. Okay, and the most commonly used drug for bipolar disorder is lithium. And lithium is the drug of choice for the treatment of mania. And maybe used with other meds to stabilize the mood, but remember, with lithium, you have to remember the normal level, and the normal level is 0.6 to 1.2 MEq per liter. Higher than that, then it means that your patient might be exhibiting lithium toxicity. And you have to know the clinical manifestations of lithium toxicity, like GI discomfort, tremor, confusion, somnolence, seizures, and possibly death. In addition to that, lithium has also an interaction with sodium, and they are both positive ion. So with lithium and sodium, going back to sodium, you've learned that sodium has a relationship with fluid homeostasis. So in short, you want to make sure your patient's hydration status is stable before you give any lithium, because overhydration or dehydration can cause the lithium levels to be unstable. And remember that the lower the sodium, the higher the lithium toxicity can happen. Okay, so the toxic levels of lithium is 2.0. The toxic levels for DIG, just a review, is 2.0, and theophylline is 20 micrograms per ml. And just to review, digoxin, we use that. It's a cardiac glycoside. We use it for heart failure. And theophylline, we use that as part of the treatment for upper respiratory tract disorders, and also lower respiratory tract disorders. Now, what do we want to see if your client is taking lithium? We want to see an improvement in their mania. It should be less. And we want to see therapeutic levels, which should be between 0.6 to 1.2. Now, the side effects of lithium are leukocytosis, increased urination, tremors, hypothyroidism, increased thirst. For the mothers, it's teratogenic. So again, we have to weigh the risk versus benefit here when we're giving lithium. Now, other drugs that we want to talk about are antidepressants. And with antidepressants, we have tricyclic antidepressants, or TCAs. We also have monoamine oxidase inhibitors. We also have newer generation of antidepressants like SSRIs and second and third generation antidepressants. So with TCAs, the most commonly used are amitriptyline, doxepin, nortriptyline, and imipramine. And with TCAs, remember that you have to watch for any suicidal ideation of your client. And you have to watch for signs of sedation, orthostatic hypotension, decreased sexual ability or desire, dry mouth, urinary retention, and cardiac dysrhythmias. Now, other group of drug would be MAOIs, and MAOIs are monoamine oxidase. And monoamine oxidase drugs, there's only 3. So what I'm showing you here are the trade names, but I'm gonna show you the generic name. So the generic name of MAOIs are the following: isocarboxacid, penelcin, tranylcypromine. So with these 3 drugs, remember that you cannot give this with any high tyramine content food. like aged mature cheese, smoked or pickled meats, yeast extracts, red wines. You cannot give these drugs because tyramine-rich foods can cause hypertensive crisis. Now let's go back. And another reminder here, no barbiturates, no meperidine, no TCAs, SSRIs, antihistamine, CNS depressants, antihypertensives, and any over-the-counter medications like nasal decongestants. Now, another group of drugs that we have to talk about are SSRIs. And with SSRIs, we use it to increase the serotonin levels in the brain. So it makes the patient feel good. And remember, with SSRIs, it can have a drug-to-drug interaction with a nerval product like St. John's wort. So you have to be careful in giving that. And also tryptophan. And tryptophan is a serotonin precursor found in foods like milk. Here, I wrote here, tryptophan. And for SSRIs, we have the following. These are the second generation SSRIs. We have citalopram, fluoxetine, fluvoxamine, paroxetine, sertraline. And when you're giving SSRIs, you have to watch for serotonin syndrome. And with serotonin syndrome, it means that probably we're giving too much of SSRIs. And the common symptoms of serotonin syndrome are delirium, agitation, tachycardia. Your patient will be sweating, will have shivering, seizures, rhabdomyolysis, cardiac dysrhythmias. So again, you have to watch for your patients about having this. Now, the second generation antidepressants, it offers a lot of advantages over TCAs and MAOIs because of their improved adverse effect profiles. So what we do need to remember as nurses is that with caffeine and cigarette smoking, it may decrease the effectiveness of the medication therapy, the TCAs, the MAOIs, and the SSRIs. So, and also, we already talked about tyramine-containing foods, right? Because it can cause hypertensive crisis. Now, we have to be cautious because when we're giving antidepressants, it can predispose the client for fall. So you have to put the patient on fall precaution because it can cause postural hypotension. And again, you have to watch for any suicidal ideations. Now, for antidepressants, what we want to see is that the client will improve when it comes to their sleeping pattern, their self-esteem, increased interest in daily activities, and of course, fewer depressive manifestations. Now, there are other antipsychotics or antipsychotic drugs like haloperidol, and there are atypical antipsychotics. So, atypical antipsychotics are newer. They are new class. They are discovered around 1990s. And there are clozapine, risperidone, olanzapine, aripiprazole, and paliperidone. Okay. Adverse effects that you want to watch for when you're giving antipsychotic drugs are tardive dyskinesia. Tardive dyskinesia, it means that your patient will have involuntary contractions of oral and facial muscles. And it occurs due to long-term use of antipsychotic drug. Other adverse effects you have to watch for are neuroleptic malignant syndrome. This can cause death to patients, to clients, and extrapyramidal symptoms, which the symptoms are similar to clients who have Parkinson's disease, but it can be treated with benztropine. Other antipsychotic drugs like pinothiazines are used for schizophrenia. Remember that you have to tell the client to wear sunscreen, tell clients to avoid taking antacids, avoid alcohol. And again, overall, we want to see an improved mood and affect to these clients who are taking these drugs and alleviate psychotic symptoms like hallucination, paranoia, delusions. And remember that, in summary, psychotherapeutic drugs cannot be discontinued abruptly. And remember that the therapeutic effect, it takes at least 4 to 6 weeks or more depending on the dosing. Remember, it cannot be taken with alcohol or any caffeine products. Patient needs to carry a medical alert or identification that they're taking these drugs. And their drug list has to be updated at least every 3 months. Avoid sudden withdrawal of the drugs. The doses need to be tapered with supervision of the healthcare provider. Again, remember the lithium toxicity clinical manifestations, the therapeutic level of lithium. Remember that lithium has an interaction with sodium. Now, when it comes to MAOIs and TCAs, in addition to what I said, is that be cautious with over-the-counter cold and flu products when taking MAOIs and TCAs. Amitriptyline, which is a MAOI, a TCA, is known to discolor the urine. So we have to tell our client about that. And mirtazapine, which an antidepressant, is also used for appetite enhancer. So when we're looking at the home medications of the patient, we have to look for what is it for, because sometimes antidepressant drugs are also used to enhance their appetite. Not technically they have depression. So that sums up the psychotherapeutic drugs.